Hello, thank you for joining us for From Assessment to Action, Understanding Health-Related Social Needs in Rapid Antiretroviral Therapy. As a disclaimer, this content in this community of practice is the sole responsibility of us as the authors and does not necessarily represent the official position of the Centers for Disease Control and Prevention. And I'm going to go ahead and pass it over to my co-presenter to introduce herself, and then I'll introduce myself.
Thank you, Ms. Jai. Hello, everyone. My name is Bev Wasserman, and I'm the nurse field consultant with the Denver Prevention Training Center. In my current role, I'm part of a team providing capacity building assistance to organizations serving clients in clinical, non-clinical, and health department settings.
Awesome. Thank you, Bev. My name is Miss Jai Smith. I am a subject matter expert with the Denver Prevention Training Center, and I have over a decade of experience working in HIV prevention and in care. So here are our learning objectives for today's community of practice. By the end of our time together, you'll be able to define health-related social needs, or HRSNs, and describe how HRSNs correspond to social determinants of health, or SDOHs. You will also be able to identify potential HRSNs with a client who is interested in starting rapid antiretroviral therapy, or ART, and we will discuss how rapid ART programs can plan, integrate, implement, evaluate, and sustain HRSN assessment with clients. As a reminder, rapid ART is when medication is initiated within 7 days of diagnosis. We will accomplish these by providing some definitions for HRSNs and SDOHs, exploring some of the data around common HRSNs, and illustrating how SDOHs impact individual HRSNs. We will then move through a scenario where you will identify HRSNs and wrap up with our think tank or the think tank questions on how to bring HRSN assessment to your Rapid ART program. Before we dive too deep into this discussion, we should set some definitions. So first, let's look at HRSNs. According to the Centers for Medicare and Medicaid Services, HRSNs are the social and economic needs that individuals experience that affect their ability to maintain their health and well-being. HRSN refers to individual level factors such as financial instability, lack of access to healthy food, lack of access to affordable and stable housing and utilities, lack of access to health care, and lack of access to transportation. These are unique individual and these are unique individual and family experiences that impact health access and outcomes for the individual. So some examples of HRSNs include financial strain, housing instability, housing quality, food insecurity, limited English proficiency, unemployment or underemployment, exposure to pollution, personal safety, lack of transportation, affordable utilities, and interpersonal violence. In comparison, the social determinants of health, or SDOHs, are the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. SDOH refers to community level factors. So examples of SDOHs are neighborhood and built environment, economic stability, access to quality education and healthcare, and community contexts. So, multiple people in a community may experience the same social determinants of health, such as poor quality housing, but each individual person in that neighborhood will have their own unique health related social needs. SDOHs influence a person's HRSNs, so they can help us to know some of the common barriers in a community, but individual assessment is still necessary to understand the person's unique experience and barriers. So I'd like to go through a quick example and then leave you with some questions to think about. So let's say someone has just had a preliminary positive HIV test result from a mobile testing clinic in a rural county. They are concerned because they are on Medicare, have a fixed income, and already can't afford their rent. They are also concerned because they live alone, have a landline phone and no internet access, have some mobility challenges, and rely on a friend to drive them to and from appointments and the grocery store. There is no infectious disease healthcare specialist within 30 miles, Mailed packages are often lost and or taken from their doorstep, and they are worried their friends or neighbors may find out their HIV status. So I'd like you to pause this video and think about what are some of the social determinants of health or community contexts that are impacting this person's ability to engage in HIV care. And then also think about what are some of the HRSNs, that is the individual experiences that are impacting this person. I'll give you just a moment to pause and think those through. Thank you for taking the chance to think through this scenario and what this person might be experiencing. So, some of the possible social determinants of health or community contexts that are impacting this person's ability to engage in HIV care might include access to quality health care, economic stability, and neighborhood issues with mail delivery or theft. Some of the individual HRSNs or health related social needs that might be impacting this person include a lack of transportation, fixed income, housing instability, a lack of internet or cell phone for any telehealth services, and interpersonal stigma related to HIV. And with that, I'm going to pass it over to Bev to share a little bit more about how these impact our care.
Thank you, Ms. Jai. So, part of our conversation today is getting on the same page with language. We use a lot of acronyms and different descriptions in public health and in healthcare. So, we're going to try to pull that together for everyone. Again, in public health, the focus is on addressing community and population level health, which in part requires addressing social determinants of health. As we know, for healthcare providers, the focus is on an individual patient's health and providing prevention and treatment for health conditions, which can require addressing those HRSNs. Often addressing the community factors that are impacting health, such as neighborhood pollution, infrastructure, challenges, pharmacy access, all those things are outside the scope of a clinic. However, the clinic can address the resulting health related social needs by knowing the context in which the patient lives and coordinating care collaboratively with community based service organizations. So we see how that collaboration is really key here. All right, let's take, for example, two neighbors. This will help us pull it into a personal context. Both neighbors experience similar neighborhood conditions, such as lack of paved sidewalks, no nearby accessible pharmacy, and the like. These are social determinants of health because they are community level conditions in the environment where all neighbors live. For neighbor one, in addition to the neighborhood conditions, they may also rely on public transportation. They may live on a third floor walk up requiring the use of stairs, and they may have low health literacy. These are the individual's HRSNs because they are unique to their individual experience and can impact neighbor one's ability to maintain their health and well being. In comparison, though neighbor two may be exposed to similar neighborhood conditions, they may not have the exact same HRSNs. They may have a more reliable vehicle that allows them to get to medical visits on time. They may live in a single floor housing unit or may have higher health literacy from more consistent engagement with medical care. Both neighbors, as you can see, are impacted by the same social determinants of health, but their individual health related social needs are different, and those require a unique approach to improve their health outcomes. Social determinants of health can influence an individual's HRSNs. Therefore, it's necessary to know lost my place. It's necessary to know community level disparities and to use that to inform your assessment of those health related social needs. Remember, those are individual and of each of your patients. This will help you build a tailored plan that includes support for addressing the social factors that contribute to poor health outcomes. Additionally, by understanding the HRSNs of the patients you are serving, you can identify common challenges for populations of focus to inform how your organization will address patient HRSNs and improve health outcomes of your patient population. To further illustrate this, we are going to look at some HRSN disparities for two populations of focus: people living with HIV over age 50 and people in rural and frontier areas. So, as you see this graph, in 2022, most people with HIV were over the age of 50. That's 53.7%. And CDC projects that by 2030, over 70% of people with HIV will be over age 50. People with HIV over the age 50 are likely to experience unstable housing conditions. This is disproportionately experienced among HIV positive older adults who identify with marginalized identities such as race and sexual orientation. Additionally, 58.6 of the Ryan White patients are living at or below 100% of the federal poverty level. So let's move on to people in rural and frontier areas. Again, in the United States, in 2019, 15.4% of people living in non-metro, what we call rural areas, experienced poverty compared to 11.9% in urban areas. Racial and ethnic minorities living in rural and urban areas are more likely to experience poverty and more likely to experience poverty in rural areas compared to urban areas. For example, Black people, 30.7% of people who live in rural areas experience poverty compared to 20.4% in urban areas. Among Indigenous people, the difference is 29.6% in rural areas compared to 19.4% in urban. And among Latinx people, the difference is 21.7% in rural versus 16.9% in urban areas. Among all of the people who report at least one HRSN, all report poor medical care. If we know these individuals and these populations are more likely to experience housing or economic instability, then we can incorporate assessing for unmet HRSNs for patients who come from these communities. We're going to move on and look at a scenario that always helps us to kind of concretize what we're talking about. Now that we know more about those health-related social needs, we're going to go through a scenario to practice assessing health-related social needs for a newly reactive patient and see how rapid ART can support this patient. Here's our patient scenario. During outreach testing in a rural community, Marcos, a 67-year-old Latinx gay man, tested reactive for HIV and is interested in rapid ART. The patient's primary language is Spanish, though they understand some conversational English. Marcos does not have a car and is living in a rural area with no access to public transportation. Marcos lives with his partner, who is not always supportive around Marcos' health needs. Marcos also lives in an area where there are no nearby clinical services and only a local pharmacy and a grocery store. So Marcos is retired and only receiving Social Security income with payments at $700 a month. Marcos is currently enrolled in Medicare, but does not understand how the coverage works and has been paying for his medications in cash. Marcos has also had some bills piling up, including a phone bill because he's not been able to afford it. Marcos' live-in partner has been physically violent in the past and is currently the only name on the lease. He is worried about experiencing violence or becoming homeless if he discloses his status or the relationship ends. Additionally, his partner is fluent as English and often assists on accompanying him to medical visits to translate. All right, Ms. Jai, I'll turn it back to you.
Thank you, Bev. So, thinking of that scenario, I want you to pause and write down some answers to these questions for yourself. So, what are some of the health related social needs for Marcos? What are some of those individual level experiences that Marcos is having for those HRSNs? Secondly, what makes Marcos a candidate for rapid art? As a reminder, rapid art is starting antiretroviral therapy within 7 days of diagnosis. And then the third question is, what are some strategies to address the most immediate needs to get Marcos the care that he needs? So go ahead and pause here, and I want you to write down a couple of responses or what you're thinking about to these questions. All right. So we're going to go through a couple of these, some possible things that you may have written down. So, what are some of the HRSNs for Marcos? So, some possible HRSNs are the language barrier. So, being predominantly a Spanish speaker and understanding some English, but maybe not medical English, and that impacting potentially health literacy, a lack of transportation, having an unsupportive partner, and we would also say potentially some domestic violence or intimate partner violence as well. A fixed income, a lack of understanding of health insurance, specifically the Medicare insurance that Marcos has, and ongoing concerns for intimate partner violence and potentially losing housing. So it seems like Marcos has lots of HRSNs up front. And while this could influence if we believe they are an appropriate candidate for rapid ART, we want to make sure that it's that we are not treating it as immediately a barrier to rapid ART. So what might make Marcos a candidate for rapid ART or rapid antiretroviral therapy? Some possible thoughts. He has expressed an interest in rapid ART or rapid art. So if he is expressing an interest, that means that there's potentially motivation to start taking medication soon. He engaging with a linkage to care specialist could help to improve his health literacy. Starting on ART could decrease the likelihood of transmission of HIV to his partner. Wraparound services through linkage to care may also help alleviate some of the other access issues that were described in the scenario. And then finally, when we think about some strategies to address the most immediate needs to ensure that Marcos can get the care that he needs, some possible answers are providing vouchers for transportation so that he is not, so that the lack of access to transportation is not a barrier, offering to support Marcos in disclosing to their partner when they are ready. Sometimes having also a mediator to disclose or a third person present can help to answer questions and also reduce the likelihood of potential violence. Referring to support for intimate partner violence or for domestic violence, and providing housing support as a safety net if the client does lose housing. So with this community of practice, we do include some think tank questions or prompts so that you can take a deeper dive into what we have talked about today, while figuring out how to apply that to the work that you currently do or would be doing. So we're going to provide you with those prompts based on these different groups. So a planning group, an implementation and integration group, an evaluation group, or a sustainability group. So think about where your program is currently at. Are you in the stage of planning to implement HRSN assessment into your Rapid Art program or implementing Rapid Art as part of your HRSN assessment? Are you already implementing it and trying or integrating it or trying to figure out how to implement or integrate it? Are you at a space where you're trying to evaluate the evaluation of HRSNs? Um, During a rapid art session, or are you in a position where you're now looking at sustainability and how to keep the program going, and what it means to evaluate for HRSNs? So we'll give a few moments for each of these slides. Please feel free to pause and take a look at these prompt questions and write out some responses for yourself. I also encourage you to work with your colleagues and supervisor around how these might be applicable to the work that you are doing and where you might be able to make some shifts in the workflow and or start either planning, integrating, implementing, evaluating, or sustaining. So are the prompts for the planning. They include what are some HRSNs your client are already experiencing? What are some resources that already exist that could help to address HRSN barriers with patients who are eligible for rapid ART? And then pick three types of resources, for example, public transportation. What practices and policies do you need in place to get clients linked to these resources while still effectively linking them to ART within 3 days? For integration and implementation, the prompts are: how can you ensure a client understands their healthcare coverage and how to utilize it within the context of their HRSNs? What workflows or processes at your organization currently hinder rapid ART linkage for clients that have multiple HRSNs? And what are three ways that you can think of to improve these workflows or processes? The evaluation think tank. For evaluation questions, we ask, what will you need to measure or what are your metrics to know if you are reaching your goals for rapid ART for clients that have HRSN barriers? What evaluation strategies have been effective to assess linkage to care or other programs within your organization in the past? And how could these strategies be used to measure the metrics you identified in the first question when it comes to linking patients to care, who specifically to rapid ART, who have HRSN barriers? And then finally, if you're in a sustainability stage, you can think about what has your organization done in the past to ensure that programs are sustainable over multiple years or grant awards? How could assessing HRSNs be integrated into what your organization is already doing to sustain a rapid ART program? And how could diversifying funding improve how your organization addresses HRSNs and initiates rapid ART? Thank you for joining us today for the HRSN and Rapid Art Community of Practice. Please feel free to connect with us on social media, either through our website, through our LinkedIn page, or through our Facebook page. And we both invite you to join us for our next Community of Practice in December of 2025, titled From Diagnosis to Dignity, Accelerating Access with Rapid Art and Outreach. We also want to share our sources from today's presentation with you. And with that, thank you so much for joining us today.